Hey everyone, we're going to talk about diabetes now. And this lecture is going to be in a series of three lectures: the overview, the medications, and the complications. So if you're looking for medications or complications, it's in a different lecture video. This one is just for diabetes mellitus overview. All right, so what is diabetes? Well, diabetes is a chronic disease that affects the pancreas, and where the pancreas is not producing enough insulin for the body to regulate glucose levels. It is a manageable disease. However, it affects multiple, I'm going to almost say that it affects the entire body, but multiple organs and throughout the body. It makes the glucose level be elevated, where that glucose, high levels of glucose damages the cells and then damages the vessels, um, the nerves, etc. And we're going to talk about complications, as I said, in a different video. It causes a lot of burden, financial burden on patients. It causes a lot of medical costs. It's the seventh leading cause of death in the United States. And the book says that it's 34.2 million of people suffering from diabetes currently. And now this number is ascending every year. So let's look at a little video here.
There are two main types of diabetes, type 1 and type 2. They're different conditions, but they're both serious. There are some other rarer types of diabetes too. What all types of diabetes have in common is that they cause people to have too much glucose in their blood. But we all need some glucose. It's what gives us our energy. We get glucose when our bodies break down the carbohydrates that we eat or drink, and that glucose is released into our blood. We also need a hormone called insulin. It's made by our pancreas, and it's insulin that allows the glucose in our blood to enter our cells and fuel our bodies. If you don't have diabetes, your pancreas senses when glucose has entered your bloodstream and releases the right amount of insulin so the glucose can get into your cells. But if you have diabetes, this system doesn't work. When you've got type 1 diabetes, you can't make any insulin at all. If you've got type 2 diabetes, it's a bit different. The insulin you make either can't work effectively or you can't produce enough of it. In both types of diabetes, because glucose can't get into your cells, it begins to build up in your blood. And too much glucose in your blood causes a lot of different problems. To begin with, it leads to diabetes symptoms like having to wee a lot, being incredibly thirsty, and feeling very tired. You may also lose weight, get infections like thrush, or suffer from slow-healing wounds. Over a long period of time, high glucose levels in your blood can seriously damage your heart, your eyes, your feet, and your kidneys. These are known as the complications of diabetes. But with the right treatment and care, people can live a healthy life. And there's much less risk that someone will experience these complications. If you've got diabetes, you can find lots of information and support.
Okay, so that's a video on an overview, but let's kind of talk about it, more in depth. So normally the metabolism is we eat and, the food is basically broken down in the stomach into fats, glucose, and protein. And that sort of goes in through the vascular system, bloodstream. And so now, when immediately that we eat, the pancreas, the brain sends a signal to the pancreas saying, "Hey, we got glucose, we got food. You need to release insulin." And think about the insulin as a key that opens a lock, just like the video says, in the cell, allowing glucose molecules to go in. So if we don't have this key, you cannot open the door or the lock, and therefore glucose cannot enter the appropriate cells. And then it just hangs around in the bloodstream, which we don't want. Um, when it basically has the appropriate key, then, glucose molecules will go into your fat cells or can go into your liver or muscles, et cetera, et cetera. When this doesn't work, then we have something called hyperglycemia. So the insulin pancreas is not working. We don't have keys to open the cells. You have all these molecules in the bloodstream of glucose. Your liver thinks that we are in deficit, so it starts producing some more. Um, and also, the fat starts breaking down, which then it produces ketone bodies. Then we're going to learn later on that those are very acidic. So, just an overview of the pathway there. There are different classifications of diabetes: the insulin dependent, which is type 1, your non-insulin dependent, diabetes 2 or type 2, and then you got your pre-diabetics that are sort of like they're diagnosed, they're diabetic, but they're barely starting it, and you might not have you have time to basically prevent complications and other sequelas. Some of the risk factors for diabetes is a strong family history, ethnicity comes into play, especially the Hispanics, the African Americans. And here specifically, yes, we talk about ethnicity, but I want you to think about the culture as well. The culture, what we eat, what these people eat, the norms that they have, etc., when we consider why are they actually a higher risk group for diabetes. It's not just because, oh, well, they're African Americans, oh, they're Hispanics. It's the fact of their norms, their culture, their foods, etc., their customs. Age also, because sometimes, as we age, our pancreas sort of gets, lazy and you develop type 2 diabetes. Obesity, huge link of obesity with diabetic 2. Sedentary life, and of course, poor diet. And then your fat, your high cholesterol, high link, very strong link of um, high cholesterol levels or very fatty food lifestyle with diabetes, as well as hypertension or high blood pressure. So now let's break it down and let's just talk about type 1 diabetes versus type 2. So, on your individuals with type 1 diabetes, it's basically the pancreas is out of order completely. Like it's not working. You have complete deficiency of insulin. It's not producing nothing or barely anything. The onset is very quickly. People that have a non-working pancreas and not producing insulin, you're going to catch it fairly early, in your years of life. So, people might be diagnosed when they are kids or very young adult. But usually it's in your adolescence and kids. um, your appearance is skinny. These people are sort of thin, and you might think, oh, every diabetic is obese. Well, not really, the body is depleted and deficient of these nutrients, and so therefore they have this skinny appearance. Typically, it's about 5 to 10% of the population, and the symptoms that they display are your three P's. And we're going to learn what these three P's are. They're polyuria, lots of urine, polydipsia, lots of thirst, and then polyphagia, lots of hunger or very hungry, and then your weight loss. You typically, some of the first symptoms is that the patients feel like tired and fatigue. They could have some blurred vision because of the dehydration process that happens of the body trying to excrete all these glucose molecules, and so it could result in blurred vision. The ketones are always present because the the fat cells are going to be broken down in order to get some energy, the body to receive energy, and then we treat them with pure insulin. This is your client that is going to need, you know, insulin with all meals and at bedtime, and possibly long lasting insulin. Here's just a little easy to read. You can pause the video and take a look at it. I'm moving forward. Now, with type 2, this one is, the pancreas might be producing some insulin. Excuse me. However, it might not be the sufficient amount. Or perhaps is producing some insulin, but the problem is at the cell level, where the cell has a issue at the receptor accepting and being susceptible to the key allowing the glucose to go in. So when you think about type 2 diabetics, you need to think about, well, it could be the pancreas not producing enough insulin, like the key, or perhaps my lock at the cell, it's not accepting the key. The lock is damaged and doesn't recognize the key. The onset is pretty slow, so these people um, could be pre-diabetic for a long time and they're not really realizing. They ignore a lot of the signs and symptoms, and then something happens where it makes them seek medical help, and then they're diagnosed, or they start developing complications, and then that's when they are diagnosed. It's most of the population, about 90% of the people. It's very highly linked to obesity. These people are obese, overweight, 90% of them. They have a very poor diet, sedentary, don't really exercise or, take care of themselves. The symptoms are all of the type 1, so all your P's, that fatigue, and tiredness, especially if they're sick or they're going through a stressful time because their glucose levels tend to increase. Hmm. The ketones are not really likely, not that it can happen. They can develop ketones, but it's not always or more likely. Like the percentage that it happens is not as common as in type 1. Now, the treatment for them is a mixture of all of these, diet, exercise, um, PO by mouth, hyperglycemic agents, and then sometimes insulin as the disease progress or as you age. And let me tell you, I've known people that been diagnosed with type 2 diabetes, and then, they lose weight or they get a gastric bypass or they start exercising, eating well, and they reverse it. They take the doctor takes away their oral hyperglycemic agents and their glucose stabilizes. So, you know, there is hope for type 2 diabetics. Now, regardless of whichever, type 1 or type 2, we need to emphasize that monitoring and controlling the glucose is very important on these individuals um, in order to prevent all these complications. So that's very important to educate to them. So here's another easy to read. pause the video if you need to. How do we diagnose diabetes? Well, we have different methods. It could be diagnosed based on one of the following. It could be an A1C of 6.5% or higher. And let's talk about what A1C is. This is a blood test that your doctor can order, and it basically tells the doctor, your average glucose level in about 2 to 3 months. So here there's no cheating or there's no lying from the client. This exam or blood test will tell you how your glucose level have been for the past 3 months in an average. So you might have a client that says, "Oh yeah, I know my glucose have been under 150," hypothetically, right? Telling you. And and then you go and take an A1C and it's at 12%. Well, I'm sorry, client, but I think your reading is wrong. So another of the method is a fasting glucose level above 126. So that means like not eating, and then you go take a glucose level. And then it could be a plasma glucose after 2 hours of eating, higher than 200, or randomly taking your glucose level above, showing above 200 and having some symptoms already. So any of these, preferably the one that they usually go with is the A1C. Um, any of these can diagnose the client. In addition, they'll take lipid panels just to see how your cholesterol is doing and your triglycerides. They might take a blood gases just to see if maybe you're on DKA. And we're going to learn about what DKA is, but it's a metabolic acidosis imbalance. Um, and then they could do a urine sample to test for ketones. Now, one thing I want to mention is that sometimes, when a client goes to the doctor and let's say their glucose level was above, let me go back to the other slide, was 150, let's say on fasting. Maybe the doctor is not going to immediately, without symptoms or anything, um, immediately just put a patient on medication. They might say, "Hey, come back and redo that exam in a week or 2 weeks." Um, so that could happen as well. Just letting you know, this is, based on my experience. So now what? We're diabetic. What is the goal? Well, the goal of treatment for these diabetics is to control and treat the symptoms. We don't want them to get worse. We want to avoid all complications. We want to promote the well-being of the clients so they could feel well, and also be educated. But and delayed any kind of long-term complication, not make it worse. So, in order to accomplish all of these, education is crucial for these patients. We need to teach our clients, we need to teach actually everyone about diabetes, not just our diabetic patients. When you're educating, also, you need to consider their culture, their background, their family, the interactions that they have, the social economics of the patient. And I'll explain a little bit further when we discuss each of these aspects of teaching why I say that. But mainly we want to educate them about the nutrition, the exercise patterns and weight control, how to self-monitor, recognize these complications and know what to do, how to take care of their feet, and then lastly, but not less important, it's actually a huge teaching point, is the drug therapy. So let's look into every single one and kind of break it down a little bit more. Um, oh, another thing that we need to also tell this client is to monitor their um, eyes, and also do dental care routinely. So what should they eat? Well, they need to have, a balanced diet. If we're talking healthy carbs, low trans fats, healthy fats instead, good fiber, less calorie, less processed foods. And so for that, we recommend that they talk with a diabetic educator or a dietitian or both, so they can consult and kind of create an individualized meal plan that focuses on the client's age and gender, weight, and perhaps their activity level. It's very individualized. You have to sort of set short-term goals. And this is where I was kind of saying we need to consider the culture and the social economics, religion, and cognition of the patient. So let me give you a scenario of what I mean. So let's say um, you tell this patient, yeah, well, you're diabetic now, you're going to have to eat a lot of veggies and, go to the store and buy all these things. Well, these healthy things are sort of pricey, Um, and let's say the client is unemployed, maybe homeless. They might not be able to afford that. Or let's say that the culture, like in the case of Hispanics, and I could speak for that since I'm Hispanic, um, let's say that the culture is like, well, you can't eat any more bread, tortillas, rice, potatoes. Well, that's kind of all, around Hispanics. They eat a lot of carbs and a lot of fried food as well. So that might not be realistic for that client. We need to involve the family big time because hey, you might tell the client, yeah, you need to cook more protein that is lean, and then let's say the mom or the grandma is cooking them pork and fried. Well, we need to tell the family, hey, listen, this is not good for them anymore, because a lot of patients find themselves being pushed by others and kind of that social pressure as well. We need to also let them know that they need to be careful with alcohol. Typically, the recommendation is men can have 2 drinks per day and women 1 drink. Give them suggestions such as, recommending light beer instead of like hard liquor, or wines that are maybe not as sugary or no wine at all, because wine is actually from grapes and it's very sugary. Also, they need to be careful with these diet items like Diet Coke and Diet this or Diet that, because sometimes it's not the best option to select, and also it lacks the calories or healthy calories that they might need. They need to learn how to read the labels, um, and kind of interpret the labels, knowing, okay, my serving size is this much. This package has these many serving size. Because a lot of people, you'll be surprised how many they say, oh, well, let me take these cookies home. They're only 10 grams of sugars, let's say. I'm giving you an example. But the package says it's 20 servings and it's one serving for 10 grams of sugars. So then here's the client thinking it's only 10 grams of sugar for the whole package, eats the whole package, but they're not multiplying that. Okay, so we need to teach them how to read these labels. They also need to know how to carbohydrate count. So the formula is like 1 unit of insulin per 15 grams of carbs, or 2 units per 25 grams of carbs. And that's going to come handy because whenever the client administers insulin, they need to kind of count how many carbs they ate in order to self administer the insulin if they're not on a sliding scale. Hmm, Sorry, I'm a little sick and I'm coughing. Um, so, with the carbohydrate counting, here's a little scenario. Let's kind of practice. So let's say you have a client at the hospital on under a sliding scale, which is a sliding scale is basically from this number to that number of glucose level, you're going to administer X number of units of insulin. So you have a client on sliding scale and carb count. Their glucose level that morning was 155, and then um, they consumed this breakfast, and we're going to look at what the breakfast is. Two slices of toast, 1 tablespoon of jam, eggs, and coffee. It's a total of 45 grams. So you have the client ate 45 grams and they had a glucose level of 155. So 155 falls under 4 units and they ate 45 grams. So 45 divided by 15 is 3. 3 plus 4. How many units of insulin are you giving this patient? 4 plus 3 equals 7. Okay, that's how you slide scale in carb count. All right, another teaching point is their exercise and the activity. And honestly, exercise is a very important part of the treatment plan for type 1 and type 2. They need to increase their exercise and mobility. It actually makes insulin sensitive at the cell, so it allows the cell to actually take the insulin and the glucose. So it's very healthy. Um, and it works very well lowering glucose levels. So it's really recommended 30 minutes of moderate intensity aerobic, five 5 days a week. So most of the days of the week, okay? Now, there's some things that we need to watch out for because, when we are exercising, it could induce kind of hypoglycemia if you are working a little hard and you've taken your insulin or your um, hypoglycemic agents, as well as it can sort of cause a little bit of hyperglycemia due to the stress in the body that exercise causes. Like if you're exercising strenuous and kind of hard, like lifting and whatnot. But yes, the recommendation is 30 minutes times 5 days a week. Another important part is basically letting your client know how to self-monitor and why is it so important to let the client know, hey, you need to know what your glucose level is every day. So pretty much knowing glucose levels tells the client how control you are. In knowing how control you are, you can make adjustments. You can know how much or how less insulin to take or or oral medication. And you can also detect complications like hyperglycemia, like DKA, or this other disease that we're going to talk later on complications, as well as how is your exercises and maybe the change in the diet and the medications that you're taking influencing and interacting with your glucose levels. Now, there are different methods of self-monitoring at the hospital. The majority that you're going to see is your glucometers, where basically the nurse or the tech goes in and takes a capillary blood glucose sample from the patient's finger. All you do is basically warm up the hand if it's cold, ask the client if, which finger they prefer to be stuck at, scan the patient, ask the two identifiers, you prepare the lancet and the glucometer, you put the strip inside the glucometer, then wipe the finger with alcohol, let it dry, stick, using the lancet, stick the finger. Um, Once the first drop of blood comes out, you wipe it with your cotton ball, and then your second one, you basically touch that tip or the mouth of the strip, and it gives you a reading. Um, Now, however, with technology, we kind of gotten a little fancy, and now we have this continuous glucose monitoring that could have a pump or not have a pump, and it's sort of in your stomach. And then, as well as this glucose flash monitoring that a lot of people have sort of in the back of their arm, and it almost looks like a scanner, like grocery scanner. You scan. The device and it gives you the reading. So pretty cool. Let me show you a picture of it. So a lot of people might have it in their stomach or in the back of their arm, and it's just continuous or just like a scanning kind of thing. Let's talk about finally about foot care. Um, foot care is huge in diabetics. Um, we need to emphasize and really drilled on them the importance of checking their feet every day, providing good hygiene, protecting their feet with good footwear, preventing any kind of infection. They need to dry their feet every day. In between their toes, check for wounds, check for pressure points. Sometimes I even tell them, "Hey, you might even have to blow dry them, like with a blow dryer." Their nails, they get thick, and so they need to visit a podiatrist. And their nails should be cut across so that way you don't have ingrown toenails. If you get any sort of scrapes or punctures or cuts in their legs or feet, you need to treat them promptly. Go visit your doctor because those can turn into very quickly into infections and lead to, worst case scenario, gangrene and amputation. They suffer from neuropathy, which is the loss of sensation. So sometimes they cut themselves and they don't even know. So that is why it's very important for them to always have shoes on with hard sole, and careful with hot water soaking their feet. Um, I think that's the overview of diabetes. For your next lecture, series 2 or episode 2, we're going to talk about the medications of diabetes, including insulin and your orals. Okay, I hope this was helpful. And as always, my references are from the book, our book, and Google. I'll see you in the next video.